Hi, I'm Jack Cush. It is the 23rd of September of 2016, and this is the RheumNow Weekend Review. I'm coming to you from Dallas, Texas, where I'm going to review some of the highlights of the news that we presented this week on RheumNow.com. Some of the tweets that came out on our social media feed. You may see those in the right-hand column of the emails that you receive, and they're worth scanning because you might find things that are of interest to you. First, a population-based report from Italy, looking at a large number of people who had autoimmune thyroiditis with very high titer anti-TPO antibodies, and showed that autoimmune diagnoses actually are not uncommon in this group, and includes a substantial minority who have either vitiligo, rheumatoid arthritis, polymyalgia rheumatica, dermatomyositis, Sjogren's syndrome, multiple sclerosis, lupus, sarcoid, alopecia, primary Sjogren's, scleroderma, and even hepatitis C related cryoglobulinemia. Some of those diagnoses you are not surprised at, some you might. Certainly worth considering that diagnosis in patients who have an autoimmune disease. Again, a review that we previously published by the NIH, but put out there again, is that in 2013, the U.S. spent $990 billion on osteoporosis, with 23% of the cost, or a total of $756 billion on brand name drugs. Interestingly, the elderly who needed drugs for their osteoporosis, only 50% were on such drugs. And that generic use for drugs like bisphosphonates and others varied between 57 and 86% of the time. A review of from the Korean literature, I believe, on gout patients taking antihypertensives and what happens to their uric acids based on the blood pressure medicine they take. We certainly know that losartan and a few others may potentially lower uric acid levels, but this particular study showed that beta blockers, alpha blockers, and not surprisingly, hydrochlorothiazide, other diuretics, significantly increase uric acid levels, and there was roughly no effect from ACE inhibitors and calcium channel blockers. An interesting case report from a few people on the East Coast. Their names escape me right now, but nonetheless, about pegloticase, and we certainly know pegloticase often fails because patients develop antibodies to the peg moiety, and then that leads to toxicity associated with the drug. They showed in their case the ability to improve outcomes in a patient by using concomitant Imuran therapy when administering pegloticase, so as to retard that anti-drug antibody that often occurs in a substantial number of patients. Something to be considered in future trials and in future patients treated with pegloticase. Early RA patients in the T-REACH cohort showed that in their analysis that they could actually increase the diagnostic yield if they changed the cutoff point for points needed for an early RA diagnosis. And so in their study, they basically use the new ACR-EULAR diagnostic criteria, which generally require 6 points to make the diagnosis. And they showed that if you lower that to 5 points, that you would actually get an increased yield, as much as 15% more patients being diagnosed with rheumatoid arthritis, and that would be at the price of an increased specificity, a lowered specificity that would go down by 8%. Something worth considering for those who work on criteria and whatnot. The Nurses' Health study showed that women with gout have a 38% increased risk in hip fractures. That's sort of been out there before, but reconfirmed. JIA uveitis refractory to methotrexate DMARDs showed that it could, and even TNF inhibitors showed that it could be successfully treated with tocilizumab in 10 out of 17 patients, with results out to 6 months. In 7 of those 10, they were able to steroid spare and lower the dose and need for steroids. So again, this, along with abatacept, shown to possibly be something you might add to refractory uveitis. Periprosthetic fractures after hip replacement seems to be higher in women, older individuals, rheumatoid arthritis patients, those undergoing revision hip surgery, And those with a prior history of either osteoporosis or avascular necrosis. All of those people being at higher risk for periprosthetic hip fractures after they have hip replacement. When they looked at the hip fracture rates in RA, a study out of Sweden showed that compared to controls, hip fractures are 50 to 80% higher in rheumatoid arthritis patients, but hip fractures tend to be 10% lower in women with osteoporosis, and those results are not necessarily explained by BMD results. An interesting look at a population study of how you use PPD and what it means later on in Spain, when they looked at patients who had a negative PPD and then repeated it in the next 1 or 2 years, they showed that there was a 4.3% seroconversion rate, and that was thought to be due to either the finding of latent TB that was masked by inflammation and recovered by control of inflammation with the TNF inhibitor. As you know, other studies have shown similar results of 5 to 10% when you do see a secondary positive PPD, initially negative, then secondarily positive. The same could be said for a quantiferin result. You shouldn't immediately assume that it's always going to be LTBI. You need to prove that it's not a new conversion and a new infection. Hence, you need to culture everything up, send those for AFBs, and you need to get a chest x-ray and ask about signs and symptoms, obviously. Preclinical arthralgists who develop rheumatoid arthritis, a study looking at what happens biologically with those individuals showed to have a decrease in CD8 and CD80 T cells, memory B cells, also in the 2 years that precede the onset of disease. Sort of interesting. And a study by Dalbeth and colleagues showed that DECT studies looking at what is the origin of the erosion in gout. Is it an inside-out phenomena? Is it an outside-in phenomenon? They showed with DECT scanning, dual energy CT scans that show those nice urate deposits glowing with a fluorescent green. They showed that these actually start on the outside and erode through bone and go through the inside. That's it happens in RA, but also in RA you get an inside-out phenomenon with marrow edema being foci of inflammation that will break through. So sort of a contrast against rheumatoid arthritis. A number of interesting news reports. A nice study in JAMA looked at what happens after first TNF inhibitors, and they took 300 patients with established RA who failed a TNF inhibitor, and then randomized them to a second TNF inhibitor or to a non-TNF other MOA biologic. And those choices for each grouping were made by the patients and by the physicians. And they showed that at 24 months, a higher percentage of patients taking the non-TNF biologic had a good or moderate EULAR response, 68% versus 52% in those who got a second TNF inhibitor. This was an open label study, but the randomization was randomized, and so they just followed them out for a year. They did show that at the end of the year and at 24 months, they had lower low disease activity scores in the non-TNF group compared to the TNF group, 45 versus 28% at week 24 and 41 versus 23% at week 23, amounting a bit of evidence suggesting that patients who fail their first TNF probably should go on a second, not a second TNF, but another biologic with a different MOA. And that would certainly be true for patients having a primary failure, meaning they never quite responded. But these data, which are compiled in patients who were secondary losses and patients who had toxicity, were showing superior results with the other MOA, the non-TNF biologic. Another recent report in JAMA looked at the utility of wearable activity trackers, such as my Fitbit wannabe here, shown to be not effective. They took a group of individuals, a large number of patients, thousands, and followed them for 24 months. Everyone got diet and instruction and whatnot, and one of the groups received the fitness trackers. They showed that both groups lost weight, and as usually is the case in these studies, not an impressive amount of weight. But those that had a Fitbit or activity tracker type device did not actually have more weight loss, suggesting that utility of these devices in fitness remains to be seen. A review of demyelinating disease shows that it's a rare event in patients taking TNF inhibitors. I don't know about you, but I often will steer clear of a TNF inhibitor in someone who has a history of multiple sclerosis or optic neuritis or what we would call a demyelinating polyneuropathy, because there's data not in our patients with rheumatoid arthritis and psoriatic arthritis per se, as much as showing that when patients with multiple sclerosis were treated with TNF inhibitors, there was signs of worsening. And there have been reports, but this review shows that these reports are really very rare. 19 in the literature were uncovered by the investigators, and when the investigators looked at all the clinical trial data, they found 2 cases among 17,000 plus patients treated with a TNF inhibitor for multiple and inflammatory indications, suggesting these are not just rare, but very rare events, making me rethink maybe whether it's wise to avoid a potentially effective drug for what may be a 1 in 1,000 or 2 in 17,000 risk, something that needs to be discussed with the patients and with your colleagues. Teriparatide is a new drug that is making its way up the ladder in drug development as a replacement for teriparatide or Forteo. This drug was reported in a recent New England Journal report, I believe, where they looked at almost 2,500 postmenopausal women, and they randomized them to receive either placebo or teriparatide or abaloparatide as daily subcutaneous injections. Their endpoint was 18 months later, and they showed that vertebral fractures were significantly reduced in those that took the active therapies. Placebo group was about 4.2%, abaloparatide was 0.6%, and teriparatide was 0.8%. Significant reductions. However, when they looked at non-vertebral fractures, those were not significant, with all the groups ranging from about 2 to 4%. There was a lower incidence of hypercalcemia with the abaloparatide with 0.6% versus 3.3% with the Forteo drug. Remains to be seen where this drug will fit in future drug therapy. So that's it for this week. Actually, there was another interesting news report, which is my last news report from Friday, which looked at the restriction of expensive therapies by pharmacy benefit managers, PBMs, and insurers. United Healthcare this past week cut off certain expensive forms of insulin in preference for the generics, and moved Levemir up from tier 1 to tier 2, and took away the most common one, Lantus, totally off the board, and replaced it with the Lantus-like generic. That's not surprising. We might see the same happen with the new appearance of the new biosimilars in rheumatoid arthritis and psoriatic disease. But what was surprising is Express Scripts has again made a move to restrict access and take away choice from our patients and from the prescriber. And they're doing this totally based on money. They say it creates competition. There's no evidence of that. And what they're doing instead is they're saying that there's a lot of expensive biologics out there. We'll just approve a few based on they're either being in the market for a long time or the fact that they have the best rebate program back to us, the PBMs and the insurance companies. And all the others, the heck with you, you're not going to be on the list. And that's a recommendation at this point. Whether it's going to be taken up by the insurers, who are likely to do that because they'll save money, remains to be seen. But what does happen in the meantime is a choice is taken away from you. Choice will be taken away from you when biosimilars become available, but to have choice taken away from you by the companies that will financially benefit from that restriction seems to be a bit seamy, if you ask me. I believe many of you feel the same way. What can we do is hard to say, but it's time to change these crazy policies. That's it. Tune in next week to RheumNow for more good news about rheumatology.